So proximally, of course, number one there is the head of the femur. There are actually several parts to the head, but we're just going to call the whole thing the head. Two is the neck. It's the region right here, and that's the vulnerable part. That's the part that is most likely to suffer shear breakage, shear force breakage, most likely to be compromised in osteoporosis and so on. Then below that, you see the greater trochanter and the lesser trochanter. And in fact, between the two is something called the intertrochanteric line. And we can just sort of imagine an intertrochanteric line as something like that on the anterior side. And that's important both as a landmark for surgical procedures, as I say, we'll talk about that in just a moment. But it's also a line, a ridge of ligament attachment. The basic ligamentous external capsule of the hip joint is going to form or emerge at that line, and also part of the vastus. Vastus muscle attaches up there as well. Now, as you look at that, as a very rough approximation, just when thinking about these things from a surgical perspective, you can see that the intertrochanteric line is more or less along the axis of the bone shaft. So that helps you. It's a little oblique to the axis of the bone shaft. So those are the trochanters, and both of these are important sites of muscle and ligament attachment. Then, of course, there is the shaft of the bone. Up here at the top, you see what sometimes is called the tuberosity, the radial tuberosity, little prominence there. Sometimes becomes calcified with age. And then you have on the posterior side another line of muscle or ridge of muscle attachment called the linea aspera. Then distally, and this is the point that we wanted to clarify in one of our earlier slides, we have both condyles and epicondyles. So remember, the proper definition of condyle is the articulatory surface. So the condyle is the hyaline cartilage lined articular surface of the joint. And then peripheral to that, usually in the case of the knee, medial and lateral to the condyles, and this is sometimes called the intercondylar cleft or intercondylar space, would be the epicondyles. The epicondyles, and those are important sites of muscle attachment. Now, we'll have a better view of this in just a moment, but I want you to also, as you look at that bone, one of the things I want you to be able to do, if I were just to show you the distal half of the bone, be able to identify which is the medial and which is the lateral side. This isn't necessarily the best illustration for that, so we'll return to that. Of course, it's very easy if you have the head of the femur up there. So let's look at this hip joint a little bit more. It's a ball and socket joint, and you can see that we have the head of the femur here. We can see the intertrochanteric line there, the greater trochanter, lesser trochanter, and you can sort of see the emerging color of that external ligamentous capsule. We'll talk about the ligaments that frame the joint in just a moment, and then you can also see the neck of the femur here, and then the head that's lined with hyaline cartilage. One of the curious things about the femur, probably a vestigial structure, notice that curious little ligament that sticks out of the top there. You're not going to find that in any of these other joints that we talk about. As I say, vestigial probably doesn't serve any function. It doesn't really, it's not required for mobility or function of the joint. Except that, and I think again we have a better picture of this, but look very closely, there's a little artery in there. That little artery. It's a branch of one of the circumflex arteries. The point being that this is an avenue of blood supply. And with disease, osteoporosis, aging, any number of conditions, what sometimes happens is as the head and the neck, the blood supply to the head and neck become diminished, the bone begins to degenerate, and that can be problematic. So those are the major features. We'll come back to that little ligament in just a moment. Those are the major features of on the femoral side. Now remember this depression, this fossa in the hip bone is called the acetabulum. And the interior surface of the acetabulum is also lined with articular cartilage, sometimes called lunate cartilage. And again, in this context, lunate just means that it has sort of a semicircular appearance. And part of the reason that it has a semicircular appearance, the picture is a little bit deceptive here, but there's a ligament that goes from the margin of the acetabulum, the acetabular receptacle there, toward the center, and there's a fatty hollow back in here. But then that little ligament eventually forms and joins this ligament that goes by a variety of names. Sometimes it's called the ligamentum teres, sometimes it's called the ligament of the head of the femur. You'll see in various other terms. Here they're calling it the ligament of the head of the femur. But I just want you to see that little fellow doesn't crop up from the center. It actually slides from the perimeter and then moves to the center and then links up with the femoral head, where it carries the little artery there. Now, some other structures I think may be more evident in other illustrations. Notice at the margins of the labral region, the lunate surface, is a little region called the labrum. And the labrum is usually most prominent over here and down here, but labrum just means lip, and in our little surgical video we'll see it being removed or excised from the joint. But it plays some role, the labrum plays some role in maintaining the integrity of that joint. By that I mean sort of locking the head, because if you look at this head is rather exposed. It's going to be moving in that little depression, and only at any given time, only a small portion, only a small range of that head is going to be interfacing or apposed to the lunate region. So that labrum helps to sort of lock the head into place to the extent that it's present. So I think that's most of what we need to mention there. You can sort of see this in a sagittal perspective, actually a frontal perspective here. The only other thing that this illustration shows is that in addition to the external capsule, which would be those gray ligaments that you see there, notice that we also see the internal joint capsule, which is the purple region there. That's the synovium. So for most of the joints, including even the knee and the joints of the upper limb, we're going to see the external capsule and the internal capsule. Of course, that internal capsule consists of a synovial membrane and synovial fluid that acts as a lubricant for the joint. And you can also see in the illustration our ligament of the head of the femur there. You also see at the margins here a very better illustration of the labrum. And this is a region that sometimes is compromised as the joint loses its integrity and that labrum begins to break down. And then the last thing I would point out here is notice the blood vessels to the head, both from, here they're labeled retinacular arteries, but in one case it comes from the circumflex artery and the other case from the obturator artery. These are the arteries that supply the head, and the head is so dependent upon those. All right, now we're looking at the ligaments that make up the external capsule of the hip joint. There are three of these: iliofemoral, ischiofemoral, and pubofemoral. What they all have in common, of course, is femoral, because they all attach to the femur distally. Another interesting thing you'll notice about these ligaments is that they're sort of canted. By canted, we mean that they don't run directly from one bone to the other. Rather, they're at a sort of an angle. And the usual explanation you'll find for that in the textbooks is this, again, is a vestige of a quadrupedal animal. If you were to bring this, if you were to bring the femur down to a 90-degree angle, these ligaments would have a more direct apposition. But in any case, be familiar with the three. I'm not necessarily going to ask you to identify them, but I want you to recognize the terms and understand their contribution to the external capsule of the hip joint. A couple of the terms with which you should be familiar. This is going to pop up in the clinical pathology later. Coxa valga and coxa vera. Now, as you look at the angle of the head and the neck to the shaft, you can see what happens as we age. And I've never cared for this particular geometric designation, but the angle diminishes, the angle decreases. And really what that means is that angle approaches more of a right angle than a 180. Now, as I don't think you don't need to be a civil engineer or engineer of any type to know that as you compare this to this, again, this is older, which is more vulnerable to breakage with the load placed on that neck, the one on the left or the one on the right? Yeah. And so what tends to happen is that as we age, there's a propensity toward coxa vera, and coxa vera again is this tendency toward the right angle, rendering the joint, rendering the femur more vulnerable. But just be familiar with those terms. If occasionally, for genetic or developmental reasons, there may be an abnormality in that angularity that can create problems for the ability of the patient to walk properly. And of course, that has to be monitored carefully in plastic surgery. So this region is very prone to a variety of fractures, the femoral neck being most common. The fractures can sometimes be localized to the neck or they can extend down the shaft. We've already talked a little bit about the terminology used to describe these fractures. What I want to do now is look at, as I've indicated, a surgical video. This is going to be a hip replacement procedure. I was going to use a lot. He goes right through. Boy, this fellow just moves right along. And I want you to pay attention to the terminology. And we're not so concerned as we look at this. I'm going to skip through some of it. We're not concerned in here with the details of the procedure. You'll learn about that later. I just want to point out the relevant anatomy and make sure you understand why the anatomy is so important. So, of course, in a hip replacement, the general idea is that all of this is going to be removed. And then you're also going to have to replace all of this, too. So there are really two components. In fact, sometimes now they put them in the opposite. Have you noticed this? Have you noticed they sometimes do reverse so that the ball goes on the hip bone and the socket goes on? I'm not sure. I think it has to do with, that's sometimes used in revision procedures. What do we mean by revision orthopedic procedure? Yeah, there was usually an initial procedure that maybe didn't work out well, and they were going to redo it. So sometimes they do that for revision procedures. So just understand, if you had breakfast recently, you may want to prepare yourself psychologically. And then the other thing I'm going to point out here again, he's going to talk about some of these bony markings with anterior superior iliac spine. You know what that is. We've talked about the intertrochanteric line. That's going to be an important anatomical marker when he makes his incision and knows where to cut. He's also going to refer to some of these muscles. We talked about this muscle when we talked about the Trendelenburg sign. That's the gluteus medius. And then this is going to be the rectus femoris here. So all of these are going to be landmarks. All right, so if we go to the volume there. He talks fast.
The ASIS is here, greater trochan is here. Here's a fold, and we go 1 finger breadth lateral, 1 finger breadth distal, and this is where our incision is.
All right, so let's go back and listen to what he said again here. See if you can.
The ASIS is here, greater trochan is here.
All right, so SIS is what? Yeah, that's the anterior superior iliac spine, so that's gonna be one of his landmarks. And then he points out the trochanteric line.
The ASIS is here, greater trochan is here. Here's the fold, and we go 1 finger breadth lateral, 1 finger breadth distal, and this is where our incision is.
So there you go. But he needed to know his anatomy to know where to put that incision.
Now we palpate the ASIS again, which helps us locate the tensor. So
All right, so he palpates the SIS again, the anterior spine, to locate what? What is the tensor of the fascia lata, which is that runs down the lateral side to the iliotibial tract. And that's what he's going to be cutting through to access the joint.
ASIS is right here. We go through the fascia, through the fatty tissue, Cobb elevator, and you can see the tensor shining through. When you see the blue, now we incise the tensor with a knife, and if you're not sure that you're in the tensor, just incise the capsule, the fascia a little bit, hemostat, and you can see how the muscle fibers are parallel to my incision.
So how is he verifying that he's actually cutting the right muscle? He's looking for the orientation of fibers. You'd hope that this would have been determined beforehand, but he's confirming it, the orientation of the fibers. That tells him he's cutting the correct muscle, the tensor. Of course, he's also applying they're concerned with bleeding here, so notice what he does as we proceed to address the bleeding. He does the vacuum device there now.
If that's the case, you know when you're in the tensor. Then release the fascia inferiorly, superiorly.
So that fascia is epimysium overlying the muscle. It's called deep fascia.
You take an Alice clamp,
This is superficial fascia.
grab the edge of the fascia,
Fat.
with a Cobb elevator. And lift.
Separates the
Fascia
deep
off.
fascia from the muscle.
There's a leash of vessels, which you can see nicely there.
Pleasant sound effects.
And we usually killy them and put a tie around it.
So I think those are circumflex. I wasn't paying attention, but usually they have to tie off the circumflex vessel. So watch what he does. I think you'll be surprised at the parents of these. By the way, these are fairly large vessels. So what does he mean by tying them off? He cuts them and then to stop the bleeding, they just put a thread around and string them. Usually too big to cauterize. Sometimes they do both.
These can be a real frustrating source of bleeding, so we try to
Look
pay
at the
attention
appearance
of
of that.
getting
It's like
these
a vacuum
really
tube.
coagulated well, because they will continue to bleed. We're looking for the lateral border of the rectus and the precapsular fat. So we have a hips putting this on the tension. We go through this thick fascia. And you can see the muscle twitches. So that's the rectus muscle, and we go right on the border of it.
Lateral
And then
border of the
the
rectus.
fat that you see here is the precapsular fat. So we go all the way down to the capsule. The precapsular fat can be a very vascular structure. It can be quite bloody. So that's why we're taking it out en bloc.
So notice what he's saying. He doesn't want to deal with the bleeding. He's going to take away a big chunk of fat that surrounds it and shrouds and cases the joint. Again, why? Because fat is heavily vascularized.
Because they can contribute to quite a bit of bleeding during the case. Now this created this triangle right here. So we take a Cobb elevator, and lift the rectus off the capsule, and we put a bent Homan over the medial neck.
Those are names of retractors, those little things he's using.
The T incision will be from here to here, and then here. So this is the intertrochanteric line. Here's vastus lateralis,
So the foot's
Tensor
off
right
your
there.
left.
and this is rectus in iliocapsularis. We make a T incision. And put a stitch in the corner. Now we put the retractor on the inside of the joint.
What was that gray fluid that you saw there?
That's synovial.
There are three important releases done. Now you see here on the medial calcar, the capsule is very.
The calcar is just a region of the femur adjacent to the lesser trochanter. It's not terribly important here, but it's just a region of the trochanter. Yeah, the region of the femur adjacent to the trochanter.
Very tight, so we take a bovie, we do an inside-out technique, we release the capsule along the medial calcar, and you'll see how that releases.
Release is a cut incision to make sure that he now has access to the head of the femur up here, which I can't draw.
And you release the capsule along the medial calcar all the way down to the lesser trochanter. Use your finger to determine whether you had enough release. So I can stick my finger all the way down to the lesser trochanter. Release number 2 is what we call the supra-acetalar release. I put my retractor between the labrum and the capsule. You can see the labrum right there. My retractor is between the labrum and the capsule. And again, I use a bovie, an inside-out technique. Between the labrum and the capsule, you take your bovie and release the capsule along the Smith-Peterson interval.
This procedure is called the Smith-Peterson technique. As I say, we're not concerned about that. But basically, in this procedure, believe it or not, he's making far fewer incisions than has been the case in the past.
Release number 3 is in the piriformis recess, and release the capsule off the piriformis recess.
Sort of a lateral rotator.
So this osteotomy guide, you line this up with your femoral axis. Now we do the osteotomy.
What is an osteotomy?
Take out the bone.
Yeah, we're just removing a chunk of bone or modifying the bone in some significant fashion. In this case, he's cutting the head off.
The osteotomy guide, we judge from where we get out on the piriformis recess and what our osteotomy needs to be.
That long thing is the saw.
Then you put the power screw into the osteotomy of the head. Now, if you made a pretty...
He's putting that screw in, just so he's cut the head off now. Now he needs a way to get it out of where it is. And so the screw is going to be his attachment point. So eventually you'll see how he pulls the head out.
With an osteotomy, you create a really sharp edge, and it's well worth taking that off with a rongeur, because they can cut your tensor when you take the head out. Okay, so we take the retractors out, and we try to rotate the femur 180 degrees. We can bring it up, and it comes out.
There you
And
go.
here it is.
Like a little baby. And you know what that
So
thing
now,
was?
Yeah.
we do an inferior capsule release right here, which is from the transverse acetabulum down. Then we resect the labrum.
Removing the labrum, you can see that's what he's doing now.
Since she is an avascular necrosis patient, her labrum is actually quite intact.
That's kind of surprising. What is he saying there? He's saying the labrum is in such good shape because this patient had suffered from avascular necrosis, loss of blood flow to the head. So why would what's the comparison he's making here? What type of patient might have a much more damaged, a much more deteriorated labrum? Yeah, osteoporosis, arthritis, some sort of more bony deteriorative disease.
And then the inferior labrum.
So we got to go.
Now we take out the fovea. There's always some significant bleeding when we do that. It can be. from the artery of the ligamentum teres.
That's a
Then we
transverse
register the
ligament.
socket.
So he's gonna make sure that whatever the prosthesis is the right length. So that's
Now we put the reamer in individually, like with a Knoker, and then lock it in situ.
That's a reamer. What do you think a reamer does? Reams, yeah, he's gonna ream everything out there on a bowl.
One over there. And then the reamer needs to be almost parallel to the floor.
Literally, parallel to the floor. Pleasant sound. Notice when he, notice how filled.
So we're
it
to the
was.
medial wall. It's got good bleeding bone, about 45 to 50%.
Good bleeding.
Closer to 25% bleeding bone, which is good. And again, we palpate, and we're going to open up a 50 socket. So we're going to use a titanium socket. The screw holes need to be on the superior aspect of the inserter. We wetted it down so it's a little less grippy, it doesn't cut.
Grip is a technical term. And what he has here is the nail, I'm gonna call it that, is the actual head in, but he has to test it in there and make sure that the length. And my mother had this done, and for the rest of her life, she walked like this because the joint was never the right length. So all of this, the steps have to be taken even at this early stage to ensure the length is correct.
Just my soft tissue going in. And then we work it in. We take our navigation track and put it on the handle, which gives us inclination and anniversary. And we shoot for around 40 and 20. 42, 43, 22, 23.
And that's what the hammer is for.
Navigation, 38 and 22. We like that. Double check. It's quite stable. We record that.
And so a lot of the rest of this is just his going through the procedure. He's going to, and we try a couple
We have a right arm retractor.
Female
On the
limbs.
left hip, you do your release about 10 or 11 o'clock, right through there.
So this is actually what's left of the femur. And then
You can see how it releases.
gain access to that. To put
We'll
that
see how the
shaft you
femur
saw
will
earlier.
pop up. You can come down a little bit to a little bit of the posterior capsule right there. This redundant capsule in the piriformis recess can be taken out. And the hip is here. So when you drop the leg down,
And the system.
so you can see how the femur pops right up into the field. We started with the starter, which is also called chili pepper, to get things started. Then the canal finder.
That's the canal finder.
We give a little bit of lateral cortex here to keep it from going into varus.
And then you know the coxa there.
And the zero broach. Now the first broach, you want to get it down as far as possible by hand to avoid poking out the side. So you can see this is almost all the way down.
So you can see he hammers and chisels a while.
Broach handle on without any retractors in there.
Glued in.
The table calls this a counterlever effect to bring this up. Yeah. Go bring it home.
He puts on a few initially to make sure the length is correct. He throws it back in the socket.
So now we put the navigation gun back into the little hole. And we'll see how close we are to leg length. We are right on the money. So we're one long. Now you can also see that the X,
Should be in the center there.
we can put the X back to where it was. Little traction. So we bring appropriate traction on there.
So as long as the assistant is helping the lady
You
walk,
can see how the X is back in the center, so we know that we repositioned the leg where we started with. And that's one of the advantages of the arch, because we can get it back to ground zero. So we actually rotate the flank in the socket. I wouldn't invert the socket anymore, because then I would be afraid
he's
that
ensuring
I'd have some
stability now.
impingement, so I know that I'm going to be stable posteriorly. Then we dislocate the hip. And then we put in the final implant. We wiggle it down as far as we can. And hit the rest of the way.
That's your job.
Perfect.
The PAs.
So we're gonna check one more time for leg length. We put the trial head on there. Reduce it. So in X-ray, she's too short. Clinically, she's even. But with such a severe head collapse, we're going to put in a minus 2.7
Because of the
ceramic
necrosis
head.
condition.
Give it 3 taps. Make sure it's stable. Push her.
Assistant rotates the leg.
So now we're exactly 2 millimeters, which is what we would expect. By going from a plus 0 to a minus 4. You can see the
To
X
compensate for the collapse of the original head.
So we're very happy with that.
There you go. Today's work. My assumption is, I'm not an orthopedic surgeon, but my assumption was that the length of the patient's leg was shorter at the time of the surgery because of the avascular necrosis. The head had deteriorated. So to bring it back to normal, they put a large head on that would be longer than the original head. But I may be wrong. All right. You also need to be familiar with the bursa. I don't think we've talked about bursa before. Bursa are present along most of these synovial joints. These are little capsules. They're generally associated with the synovium, but not always. These are little capsules filled with gelatinous fluid that act as sort of protective cushions or protective pillows. Now, in the hip joint, you can see the prominent location of a few of these. These are synovial bursa that are very much associated anatomically with the bursa. We'll look at, we'll see a better illustration of the synovium and the knee. But there are also some that are medial. And the general function here, again, is just to protect not only the bones, but protect the bone. He talked about in that operation about cutting the muscle. If he didn't abrade the surface of the bone, it could cut the muscle. So these things are also designed to protect overlying ligaments, muscles, connective tissue, and so on. And they can sometimes become inflamed. As a PA will learn all about various types of bursitis. They can become inflamed and can be a considerable source of pain to the patient.
I'm going to tell you a little bit about hip bursitis. There are 2 main bursa in the hip. Bursa are just these fluid-filled sacs that provide lubrication anywhere a tendon rubs across a bone. One is called the trochanteric bursa, which is this bony prominence right here. And that's where you get these people that say they have their hip pops back and forth. You can hear about snapping hip. And that bursa becomes inflamed, and then it just hurts. It hurts to both touch, it hurts to roll over in bed. The other bursa is with the iliopsoas tendon, which is one of the tendons that allows you to flex your hip. And that bursitis would hurt in the groin area. Bottom line is, these can be prevented. If you work on flexibility, a lot of people avoid that, but if you work on your flexibility, you can avoid a lot of these bursitis. If they do happen, very often physical therapy can be helpful, or you can see your orthopedic surgeon, and they can put some anti-inflammatory medicine down on these bursa. So don't forget to stretch, and hopefully you can avoid bursitis.
One of your predecessors worked with this Livestrong. I forget if it was last semester or the previous semester. All right, so we've been talking about the structural components. Let's talk a little bit about the muscles. Now, I have listed here the major hip flexors and hip extensors. These are not all equal in terms of their ability to flex the hip. The first 2 are the important hip flexors, and he just talked about these in that little Livestrong animation. The psoas and the iliacus, here's your psoas here, here's the iliacus over here, and then they sort of converge inferiorly to become what's called the iliopsoas muscle. But these are your primary flexors, and we're going to define what we mean by hip flexion. Third, and along a distant third, is the rectus femoris, which is a anterior compartment thigh muscle. And it has some unusual anatomy, but it's primarily acting on the knee rather than the hip. But it also contributes to flexion of the hip from its distal attachment. And then the bottom three are only marginally. We sometimes include these as flexors. In fact, we could include some others. The sartorius, the tensor, which is actually more of an abductor, and then some of the adductors, which are actually pulling the leg toward the median plane, also contribute to some extent to flexion of the hip. And then the most powerful of the extensors, even pulling the femur the other direction, is the gluteus maximus. And the gluteus maximus is important for everything from standing from the sitting position to going upstairs and so on. And then the hamstrings, the posterior compartment muscles of the thigh, also can contribute to extension of the hip. In the cadaver images you see, so in the central image we can see the psoas once again, that's the psoas there. Here's the iliacus over here, and as we indicated, they converge to form the iliac psoas. The muscle labeled 4 in the center illustration is something called the ischio-coccygeus. We'll talk about later. What we're looking at there is something called the pelvic diaphragm, and the ischio-coccygeus contributes to that, and we'll defer a discussion of that until later. Over on the top left, you have the gluteus medius we talked about in association with the Trendelenburg sign. The piriformis, you can see, acts as something of a lateral rotator there. Sometimes as a PA, you're going to encounter, it's sometimes called the golfer's muscle because it becomes painful in certain types of very specific standing matters. Sometimes they have problems with the piriformis and so on. We talked about the importance of the sciatica, just that massive nerve that runs down the back of the leg there. Notice the semitendinosus and the semimembranosus over here, and then the biceps femoris here. These are going to frame that little hollow that you see at the back of the knee there. We'll return to that later. Oops. And then over on the right side, we have the gluteus minimus that's interior to the gluteus medius. So we moved the gluteus medius over, and we're looking at J there, the gluteus minimus. The quadratus femoris, again, is more of a lateral rotator. In fact, all of these the Gemelli family there, the Gemellus twins, are acting as weak rotators of the femur. And then we've talked about the sacrospinous and sacrotuberous ligament, not very clear in this illustration, but remember those two contribute to forming the pelvic outlet that we'll be returning to later. Very important ligaments. So these two slides just summarize what I've been talking about there, and you have a summary table given if you want to work your way through that. Another important anatomical landmark of which you should be familiar is something called the femoral triangle. The femoral triangle is this region right there in the inguinal region there. And the reason you want to be intimately familiar with it is because of all the important structures that are housed along that inguinal canal or ligament there. The femoral nerve, the femoral artery, the femoral vein, and along with those, some of the important lymphatics and additional nerves for that matter. So here's the inguinal ligament there. And then it's also framed by the sartorius and the adductor. So remember, the adductors are pulling the leg in. So there's going to be your adductor longus, and then here's your sartorius over here. So this is our femoral triangle here, and then you can see the important structures that lie within that. Notice in this illustration that all of those structures are deep to or interior to the inguinal ligament. Then the femoral artery and vein, not the nerve, because remember the nerve peters out right here and it just sort of explodes at this point. You can see the femoral nerve branching into a variety of smaller structures. But the femoral artery and the femoral nerve are going to follow what's called the adductor canal. The adductor canal runs just deep to the sartorius muscle there. And if you pay attention here, you'll see that these structures also run deep to the vastus. So this picture is a little bit deceiving because they overlie, the artery and nerve overlie the longus muscle, the adductor longus, but they run deep to both the sartorius and the vastus. In any case, they emerge inferiorly just above the knee on the posterior side, because remember, all of this is anterior right there by the inguinal ligament. They emerge at what's called the adductor hiatus down here, and they're going to join up with another nerve. There's another nerve, not the femoral, but another nerve that joins them there. By the way, the nerve, at least to about this point, it runs with the femoral artery and the nerve is that saphenous nerve. The saphenous nerve, remember, is the largest branch, the longest branch of the femoral. Yeah.
Sorry, did you say in the image on the left that those nerves are supposed to be lying into the vastus medial?
Not so much the nerves, but the vessels. The nerves go all over the place. The saphenous is the one that probably is the easiest to follow because it sort of runs medially. Actually, it runs with the artery and nerve to about the midpoint, and then heads over medial and then superficial. So I was warning you, I want to make sure that you noticed the relationship of these structures to the inguinal ligament, because I always find these illustrations, and they're all over the place, don't know what to tell you, but this is your typical illustration of something called the femoral sheath. Femoral sheath is actually this little region right here. But sometimes in the text, this entire thing is called the femoral sheath. I'm not too concerned about that, but what I do want you to pay attention to is that this illustration is a little bit deceptive, because be sure you understand that all of those structures run inside. They run deep to the inguinal ligament. But there they are, and this is the other key point. The femoral nerve, the artery, and the vein, along with some inguinal lymphatic structures that you will use in going to palpate the clinical diagnostics. There again, all of these structures running deep to the inguinal ligament. In terms of the surface anatomy at this point, I expect you to be able to recognize these abbreviations. For example, what does the TF stand for? Yeah, the tensor of the fascia lata. The rectus femoris, there would be the sartorius sort of running along that plane. We haven't talked about the vas, the vastus, lateralis, the adductor of Magnus there, vastus medialis, patella, patellar ligament down here. And then on the posterior side, of course, that dashed line is the general trajectory of the sciatic nerve. The sciatic nerve is going to branch, as we saw before, into the tibial and fibular nerves. The tibial will continue the straight shot down through that fossil region there, and then the fibular is going to branch off. Remember, though, when I talk about the common fibular nerve, what's another name for that? Yeah, the common peroneal nerve. So just be aware of that in the reading. You'll see both, and I never know. I can't give you any pattern. So in these next few slides, we're looking at the compartmentation of muscles in the thigh. And this is done in a variety of ways. We're just going to make it very simple here. There's an anterior compartment in the thigh, an anterior, medial, and posterior compartment. Now, that's going to change as we move into the leg. We're going to have an anterior, posterior, and lateral compartment. So don't confuse the thigh and the leg. But here we just have the three. And normally we denominate these with respect to function. So the anterior are the quadriceps muscles. The medial are the adductors, and the posterior, for the most part, are the hamstrings. Now, it's a little more complicated than that. I have a couple of slides that will address the complications later. Recall in our discussion of the fascia lata, we said that that external encasing membrane system also penetrates deep to the femur to generate these compartmentalizing septal membranes. And these septal membranes, in effect, are actually separating the three muscle compartments. So in this particular section is a little bit higher. It's a little too high, in fact, to be useful. But so here's our anterior compartment there. And so in the anterior compartment, you can see the vastus lateralis. That would be all of this. You can see the vastus intermedius sort of deep there. And then the rectus femoris up here, and then the vastus medialis over here. So all of that is your anterior compartment, chiefly the vastus and the rectus femoris. Over here is the adductor compartment, or the medial compartment. And you'll notice a couple of muscles over here that we just sort of, that really do not contribute to any of these functions. There's the sartorius there and the gracilis there. So they're not prominent figures in either of the discussions. But here is going to be the adductor longus, and there's the adductor magnus. The magnus you can see being much larger, much more powerful. And then in between the two is the relatively small adductor brevis. By the way, before we leave the medial compartment, notice the location of the structures we just talked about in the adductor canal. Femoral artery, femoral nerve, and the saphenous nerve way up there are all packed into that little adductor canal in the medial compartment. And then finally, here's our posterior compartment down here, primarily consisting of the biceps femoris, which you can see are these two muscles over here, this being the larger of the two heads. And then the tendinosus and the membranosus. Medical students usually learn the membranosus begins, what do they say, begins deep and runs medial. Begins deep and runs medial. So here it's going to be deep for the tendinosus, and then toward the knee, it becomes more medial. It's actually on both sides, but it becomes more medial at its attachment to the tibia. Tibia, I'm sorry. So let's take a break there and we'll pick up there.